Hello, everyone. Good day and a warm welcome to Roundtable 2 of the African Health Catalyst Forum, a strategic initiative that is co-hosted by the Africa CDC and supported by a coalition of dedicated partners.
This forum was conceived as a space for honest, high-level dialogue and, most importantly, action. We are responding to a defining moment, a sharp contraction in global health aid that has left many African health systems vulnerable. This moment is also presenting a once-in-a-generation opportunity to reshape those systems to be more sustainable, equitable, and locally led. In Roundtable 1, held last month, over 200 stakeholders from 24 countries gathered to reflect on that challenge. Our team then, A World of Opportunities, set the tone for the series. Heard urgent calls to move beyond vertical aid-dependent models and toward integrated, efficient, and community-anchored systems. Panelists highlighted the promise of political will, local innovation, and smart governance to drive this transformation. Today, in Roundtable 2, we move from vision to strategy. Our theme today is more health for the money, and it asks, how can we get to better results from the resources we already have? We will explore what it takes to achieve true value for money in African health systems. And for this roundtable, we are truly privileged to have as our moderator, Dr. Baz Simo. She is a physician and a respected leader in global health with extensive experience advancing public health systems and partnerships across Africa, Asia, and Latin America. Dr. Simo has held several high-profile positions in NGO, private sectors, foundations, as well as multilateral agencies, where she held global efforts to strengthen health systems, promote health security, and advance equitable access to care. Dr. Simo's work spans the fields of HIV/AIDS control, health governance, and capacity building in fragile settings. She is involved in academia as an associate clinical faculty in global health at the University of Washington. She brings a wealth of insight into what it takes to make systems work better for governments, for communities, and for future generations. Dr. Simo, we are honored to have you lead this important conversation. Je voudrais également rappeler à notre audience francophone de suivre le lien sur le chat pour l'interprétation en français. Over to you, Baz. Thank you.
Introduction. Good morning and good afternoon, depending on where you are. Welcome again to Roundtable 2 of the Seizing the Moment, Africa's Roadmap to Self-Reliant Health series. This important dialogue is co-hosted by the African Health Catalyst Forum and the Africa CDC in collaboration with our valued partners, Cutting Edge Public Health Solutions, EpiSolutions, the Africa Hub for Innovation and Development, PMP AHFID, the Policy Innovation Center, and the Jardin de Zoey. The first roundtable in the series of 4 laid a strong foundation by asking bold and necessary questions about aid dependency and the urgency of health systems transformation on the continent. As Dr. Pat said, today we shift our focus to solutions, not just ideas, but actions. What does it truly mean to achieve more health for the money? Who is already doing this effectively and how? And how can we build on what works, not just in theory, but in practice? This session is a space for sharing bold, proven and scalable strategies that highlight the strengths of African leadership, innovation, and partnership. Our shared goal is clear: to leave this roundtable not only inspired, but armed with concrete, actionable strategies that can be applied across the continent. We have 3 objectives for today's session. The first is to explore and showcase models, tools, and policy frameworks that drive impactful, efficient, and transparent use of existing health resources. The second is to highlight scalable, African-led, evidence-based solutions that demonstrate value for investment. And the third is to shift the conversation from cross-cutting to smart investment, equity, and systems transformation. Today's roundtable is structured in 4 parts. We'll begin with a moderated panel discussion, followed by a live Q&A session. After that, we'll open the floor for reflections during an open mic segment. And finally, we'll close with a summary of key takeaways from today's conversation. Before I introduce our esteemed panelists, a few quick reminders. French interpretation is available for participants who need it. And please use the Q&A function throughout the session to submit your questions. We'll bring them forward during the discussion. Thank you for being here, and now let's get started. It is my great pleasure to introduce our distinguished panelists who bring deep experience and diverse perspectives from across the continent. Representing East, West, and Southern Africa, our speakers embody the regional richness and leadership that drive innovative health solutions in Africa. Each of them brings a unique lens, from government policy to frontline implementation. And together, they reflect the collaborative spirit needed to realize a self-reliant and resilient health future for Africa. Please join me in welcoming Dr. Simon Kibias. He's a Senior Deputy Director of Medical Services at Kenya's Ministry of Health and Acting CEO of the Kenya Hospital Authority Trust Fund. He founded the Public Health Society of Kenya to promote the profession and support young practitioners. Dr. Kibias is a graduate of the University of Nairobi in medicine, and he obtained his MPH in Zoey Universiteit in the Netherlands. His experience has led to development of major initiatives, including the National Public Health Institute Emergency Operations Center, AI Hazard Plan, and Kenya's first referral strategy. He played a vital role in Kenya's COVID-19 response and supported local PPE production concept. Dr. Kibias began his career in 1996 and has held various leadership roles in Kenya and Botswana. He has shaped national TB, HIV, and disaster preparedness programs and contributed to achieving WHO targets. He's currently pursuing a PhD in disaster risk management and is a member of the Kenya Medical Association, Quest Global Advisory Council, and Ideal Health Organization. Our second panelist, Dr. Yewande Olaifa, works with the National Agency for the Control of AIDS that is responsible for the multi-sectoral coordination of the HIV/AIDS response in Nigeria. She holds a medical degree and a Master's of Science in Health Science Systems Management. She's a Deputy Director in the Community Prevention and Care Department, a Special Assistant to the Director General on the Presidential Treatment Program for people living with HIV, and is currently leading the agenda of the sustainability of the HIV/AIDS response on behalf of the agency. And last but not least, our third panelist, Dr. Wami Dikobe, is a public health expert with over 15 years of experience in clinical practice, research, and program implementation. She holds a medical degree and a master's in public health with specialization in health policy and management. Dr. Dikobe is the founder and CEO of Circle Point Consultancy, where she provides strategic support to governments, civil society, and private sector partners. Her work focuses on improving public health outcomes through innovative, cost-effective, and sustainable solutions. She previously served as country director for FHI 360 Botswana, leading USAID PEPFAR-funded programs, and works closely with the Ministry of Health and local organizations to strengthen health systems and improve service delivery. A warm welcome to all of you. So, to start us off, and this is to our panelists, I'd like to invite each of you to share your opening reflections very broadly with this question in mind. What does it truly mean to get more health for the money, especially in the context you work in? Is it about spending less, spending smarter, or reimagining how we define value altogether? We'll start off with you, Dr. Wame Dakobe.
First of all, I'd like to say thank you, Buzz, and I'm very happy to be here to be part of this powerful discussion. Good afternoon to my fellow panelists and to the participants who saw it fit to join us this afternoon. I'm looking forward to enriching discussions. So what does it mean to me when we say health for money? To me, it means that we will use the available resources in the most effective, in the most efficient, and in the most equitable way to maximize our health outcomes for our beneficiaries. And we know that this is extremely important in this climate that we find ourselves in with the decline in donor funding. So what does this mean in practice? I think it means that we need to prioritize high impact and cost-effective interventions. We know that immunizations work. Let's make sure that we have high coverage. It means that we need to invest in prevention. In my country, we have reached epidemic control for HIV, but we still see high new infections in young people. So we know currently with the donor climate that this is not a priority for especially USG funding, but we still need to invest in some of these interventions that are high impact. It also means that we need to strengthen our health systems, especially at primary healthcare level. And I'll speak a little bit more about this later in our discussions as I give examples on Botswana. We need to invest in digital health. We need to invest in data systems and use data for decision making, which is an area that I think is still lagging behind in most of our contexts. It means that we really need to scale integration of services. I think with HIV, it brought in this working in silos, and it probably worked at that time. But we now need to re-engineer our systems and make sure that we are integrating systems so that we are most efficient. And I think it also means that I come from a background of working with communities. So for me, it means that we need to really leverage on community healthcare workers and strengthen our community health systems so that we're getting the most out of them. And lastly, I think it means that we need to partner with the private sector and see how we can increase our domestic funding that way. So in a nutshell, I think you asked if it means just the value or if it means efficiency. I think it means all of those things, but I think beyond donor funding and beyond everything else, we want to make sure that we are providing the best possible care to our beneficiaries in the most efficient way. Thank you.
Thank you so much, Wame. Great response there. We'll move on to Dr. Kibias. Can we hear from you?
Thank you so much, Dr. Semo. To get more health for the money, for me, would really mean that we have to, in an African context, have to think of how best we can get more impact on the money we have rather than whether we need more or less money. And that means we must spend the money we have on a high impact interventions or strategies that have high returns. And that means we have to think, have a strategic purchasing of healthcare services. For example, we must employ some kind of priority, cost-effective analysis in a way as to come up with the health strategies that have high impact, so that the money we have, before we ask for more money, we already are spending money getting the best out of it. And in our context in Kenya, for example, the government of the day has prioritized preventive promotive health in its agenda. And that sits well in answering this question here, because there is more focus now on delivery of universal health coverage through primary health care. So for us to get the most out of the money we have, the little resource we have, we really have to prioritize long-term investments in health. That means we must have a long-term vision in what we implement in the health sector. We need to have prudent financial allocation based on priorities rooted in the community involved strategies, meaning that the strategies that have the foundation by the communities, especially around the primary healthcare, are the ones that have a chance to give us the highest impact for a long-term duration. So we really, I think we'll talk more about when your issues of scale up, but what I would like us to understand about getting more health for the money is not necessarily to talk about whether we are spending more or less. Most countries already probably have not attained the budget allocation of 15% of the budget allocation, most likely because probably the money spent in the health are not cost effectively utilized, meaning that probably there's a lot of wastage, a lot of privileges, and that leads to outcomes that have low impact. And looking at the progress to the SDGs, that tells us a lot, because we are not yet there yet. 2030 is near, meaning that possibly the strategies we are employing are not of high impact. So I think it is, for me, the best foot forward in investing in health is what is more important is involving the communities and promoting primary healthcare for preventing disease and creating a well-being of the society, so that we get the best out of what we invest in.
Yes, thank you for those opening thoughts. I would like to move to Dr. Olaifa and hear her thoughts really quickly.
Dr. Bassem. So from my own perspective, and I think taking notes that we're essentially speaking with one mind when Dr. Giles and Wami also spoke, it's really about leveraging on interventions that currently exist within the country so that we can actually continue to do more with what we already have. And it's also about collaborating within the sector and also reaching out to other sectors to help us get things that need to be done. So, for example, when you're talking about creating awareness for certain interventions or products in the health space, other sectors like the communication ministry would be very critical for us to engage with. But most critical is actually efficient use of the resources that we already have, looking at what it is that we're doing and see how we can reduce wastage, looking at what we're doing and asking ourselves, is this really working? Should we still continue to do things the way we're doing it? Could we do it differently? as well. And one of the things when the current global aid policy had come upon us that we had to do was to ask ourselves, what other projects do we currently have that we can leverage on to address the gap? Incidentally, we had started an intervention that was supposed to beef up primary health care in the country, and we just realized that this was an opportunity to see how we can actually leverage that to address the human resource gaps that we're now going to face with the global aid policy change. So I think it's, like I said earlier on, in summary, collaboration, accepting that you can't do it alone and reaching out to others, making efficient use of our resources is critical for us to be able to actually get more help for the money that we have. Thank you.
Thank you so much for that. And I'd like to move us on to the moderated dialogue right now. And so I'll start with you, Dr. Olaifa. In the simplest terms, what should a strong and effective health system look like in the African continent? From the perspective also of the average person, what should their health system be able to deliver?
Okay, so a strong and effective system in the African context essentially goes back to asking ourselves what are our own health priorities? What will be the priorities that we want to address for our own people? It also looks at how we can ensure that individuals or communities actually have access or receive the health services that they need, whether it is health promotion, whether it's even preventative health or curative and palliative health interventions, without actually creating some level of financial hardship. So we're essentially saying reducing the out-of-pocket burdens that people are actually dealing with. It's also about delivering services to populations in an integrated manner. The system, despite its best efforts, there is still fragmentation, and we need to ask ourselves, how can we do this? How can it have a scenario whereby a client can enter a facility and can comfortably say that it's actually a one-stop shop for meeting the needs of not only the individual but members of the family, particularly a woman who comes with her child. If we look at the definition of health, we will begin to see that it's not only looking at a physical state of the people, it's also looking at well-being, social well-being, and the mental health. You begin to realize that the health sector in itself can't do this work on its own. So adopting a multi-sectoral collaboration is critical. So working together with the education sector, agriculture sector, housing, transport is also critical for us to change the way in which we look at an effective system in the African context. The other thing that Africa needs to do is to just look at the building blocks for health, for example, and ask themselves which of the elements within each building block might actually be a game changer. So, for example, for service delivery, one of the things we've been able to learn from the HIV program, for example, is that people-centeredness concept. How do we break that into health in the general spaces as well? Health workforce is a big challenge for us in the African space, and what we need to do is to ask ourselves, how do we motivate our health workers to actually stay in our countries as opposed to leaving to greener pastures, as they've actually indicated. For health information systems, maybe we should change the way we look at things and move away from just looking at tracking health indices, but also track critical enablers to see whether if we can address that, we can also improve our health indices. If we look at the other question, that what are the perspectives of the average person, I think we should look at the average person in two forms: the average person that accesses health and the average health provider that provides his health. Their perspectives are quite different. The average person that accesses health is looking at something that is tangible. They will probably most likely focus on curative health, but they want it in an integrated manner And also, they might also accept the preventative care if they truly understand what it's supposed to do for them, such as immunization, but they also would like it to be easily accessible and, of course, not so expensive. In fact, at zero cost to them. But the health provider is always seen as providing curative health. That in itself is a burden for the health provider, and considering the fact that we're losing them in drones, it would, from their own perspective, they would like a scenario whereby people are not so dependent on curative. They don't have to deal with a huge burden of providing curative care, but they would like to also bring in more of health promotion and preventative care into the mix, which creates a more balance of the 5 components of health. Thank you.
To move on to Dr. CBS, which areas of health spending are most vulnerable to inefficiencies or wastage, and what targeted interventions have proven effective in mitigating these losses?
Thank you, Dr. Sema, for your question. In order to improve on efficiency in funding in the health sector, I think first and foremost we need to embrace the evidence-based budgeting with real-time data matched to match the investments, so that we track the high-impact interventions that have been funded. The budget execution rate also must be tracked, so that any unspent funding is flagged out early. A prudent public financing management system also needs to be in place, so as to ensure that the funding is done efficiently and any bottlenecks identified. There is also the need for participatory budgeting. The whole of sector approach in the budgeting is missed. That is when now a lot of inefficiencies occur, because we will have duplication of budgets, overlaps, and that creates inefficiency because more money is spent on the same programs within the same domain. So a lot of inefficiencies occur because the budgets sometimes are also not aligned to the burden. So if money is spent on the same condition that has already been subdued, or a condition, a disease burden that has already been brought to the minimum, then there is wastage of funds. So it has to be aligned to the burden, disease burden, and a lot of the funds be directed towards service delivery, so as to minimize on overhead expenditures. So it should also, like I said earlier, be focused on long-term system goals or the vision of programs, rather than being influenced by possibly local politics, and then the funding moves around circles where more money is spent on the same issues, just popularity sake. So there is also need to, like I said, involving many stakeholders, civil society, those who are in the front lines of the health sector. Their voices also need to be heard, because they have this capacity to flag out any inefficiencies that may arise in the funding of the health sector. And like I also said earlier, we may have to go back to say which strategies based on health technology assessment tools or cost-effective analysis, which strategies would give us the highest return on our investment, which one will give us the highest impact. So far, we know at least a lot of the primary healthcare interventions will really go far in giving us the best outcome. We also may have to improve technology in ensuring that we reduce inefficiencies in the financing system in our health sector. I think that is what I have for now on that. Thank you.
Thank you. Can I just quickly ask you which areas of health spending are most vulnerable to inefficiency or wastage? Is it medicines? Is it human resources? Is it infrastructure? From your experience, just a quick response, please.
Thank you. Thank you for that rejoinder. I think from practical point of view, we've seen a little bit of infrastructure and also health products and technologies to some extent. When we prioritize curative services because they are more visible, some for feasibility, some players in the sector may choose to construct buildings, hospitals, infrastructure. They may favor that over preventive and promotive services which are not visible to the people, or those who have funded who have given the funds. So that there is suspect because most of it may not have high impact, but visibility is there. But there's not much value for money because obvious reasons. We still need to reach out to the people and not the infrastructure. So infrastructure and a bit of the health products and technologies, if the drugs being used are not effective, for example, if the line of the drugs that are bought are not effective in controlling the disease, then you will be forced to buy a second line treatment, for example. There has to be a credible essential medical list that has been approved by a team of experts so that for the little money you spend, you get the cures you need. I've worked in the TB program before, and that was very important for us. We must make sure that there is a good adherence to treatment for the standardized medications that have been approved across board, above board, and that you achieve the highest cure rates and treatment success rates.
I really appreciate your response.
Thank you.
This next question is for you, Dr. Dikobe. The health workforce is both one of the largest and one of the greatest gaps in Africa. It's one of the largest investments and one of the greatest gaps in the African health system. How can we improve efficiency, distribution, and impact in human resources for health without compromising quality and equity?
This is another area that's a huge gap for us in the African context. It's said that in Africa, we have 24% of the disease burden with only 3% of the workforce. And we know that this is worse as we get into rural areas and underserved areas, and especially for the ratio for doctors and nurses. I think most African countries are unable to meet the WHO ratio. So to improve efficiency, distribution, and impact, I think one of the things that we can do, which is a low-hanging fruit, a quick win, is again a lesson learned from HIV programming with task shifting, where we had nurses providing ARVs, we had lay counselors providing testing, we had community healthcare workers distributing medicines in the community. And I think this can be expanded to other conditions, especially now with integration of NCDs and as we see a rise in NCDs. I also think that in our African context, often we do not match the skill set with the environment. So I think a lot can be done in collaborating with the institutes, the universities, the nursing institutes, to make sure that those that are trained to work within the environment and that they have the right skills so that there's no mismatch between the skills and the needs on the ground. And then in terms of distribution, one of the areas that I think we can really leverage on is leveraging on technology in this regard. In my past life, in my previous role, we provided technical assistance to Minister of Health here in Botswana to utilize IRIS. The system was there, but it wasn't being used. So again, leveraging on technology to make sure that we use it to know where our health force is, the kind of skills that they need, and how to distribute them to where they need to be. And I think we have really great examples in the rest of Africa. Uganda stands out as a country that has really good iris utilization. Kenya and I think Nigeria also stands out, where we've even linked it to from a registration with professional bodies and tracking of professional development throughout one's career. So I think those are some of the things that are quick wins and can be optimized for more efficiency, better distribution, and for impact. Thank you. Over.
Thank you so much. I'm really happy to hear you talking about IRIS because it is such a powerful tool when it comes to the distribution of healthcare workers, as well as the sort of upskilling and just monitoring of the training of healthcare workers. All right, we're going to move on to another question related to inefficiencies in budget allocation. Dr. Olaifa, how can we reduce inefficiencies in budget allocation to ensure that limited health resources are directed towards the interventions and systems investments that deliver the greatest impact?
Thank you. So I think one of the greatest challenges that we have in Africa is actually letting data speak to how we allocate resources. And that's really critical going forward. It's not enough for us to have resources, but we should be asking ourselves, why are we plugging in resources into certain areas? What is the data telling us about what we should be doing? The other thing is, even when we do make investments, we should be asking ourselves, those interventions that we want to invest in, is it actually cost effective? If not, then we should ask ourselves what other cost effective intervention can give us the kind of results that we really want. The other things that we should be looking at is how we can begin to integrate our interventions, focusing on population and their great and their diverse needs. It's a tricky pathway to take, but it actually helps us to be able to provide that integrated intervention for people as opposed to programming along different streams of diseases. So, and that, for us to be able to do that, we do need to work towards a stronger intersectoral collaboration rather than working in silos as we currently have in the system. But one of the other things is that because we are kind of like balkanized and working in silos, we have different resource management frameworks, whether it is for government, private sector, or donor funding. And what we actually need to do is to start moving towards a single funding mechanism so that we can efficiently use our resources as the country goes forward. And I think these kind of things are some of the things in which we are trying to do in Nigeria when we decided that we were going to go through the sector-wide approach where we adopt a collaborative strategy, brings everybody together from whether you're government, you're non-governmental, or you're private sector, under a unified framework where we begin to view what we need to do collectively for the people. We enhance the resources that we currently have. We reduce the duplicative efforts that is currently ongoing and ensure that the health interventions would still align with the national priorities. To ride on to that, when the global U.S. aid policy actually changed, initially when we did the swap, we did not bring in HIV, TB, and malaria. It was kind of like a headache to see how we can do that because the partners were still there. But the moment that U.S. government policy change actually came to be, we had an opportunity to actually begin to bring those three diseases under the swap conversation. One of the ways in which we operated under the swap was to have technical working groups to address different areas. And with that, we had an opportunity to have an ATM technical working group that covers HIV, TB, and malaria, was chaired by the DG and the Director of Public Health in the Ministry of Health, and it brought in other players in the sector from the primary health care, health insurance, disease control, even the leadership at subnational level, just to work together to see how we can respond to what is currently before us. So with that, I think we should actually be able to just help ourselves use data to guide, work with cost-effective interventions as opposed to what's nice to do, and then of course work together within the sector in a collaborative manner, both government, government, private sector, and non-governmental organizations. Thank you.
Thank you so much for that response. Really interesting to hear how you broadened the sector-wide approach to include HIV, TB, and malaria there. What a great example. I'm now going to move on to Dr. Dikove again for you to share practical examples where countries or programs have achieved better health outcomes or greater efficiency without relying on external donor support. It will be really interesting to see what examples you can share in this area.
Yeah, so I'm going to start by sharing examples from Botswana. I think that, Botswana has really good political will and commitment in terms of commitment to providing health services. And I think, we've seen this over the years. My government procures its own drugs. We procured ARVs, even with donor funding, to make sure that those are safeguarded. I think in case something like this happens where donor funding declines. There's also strong commitment in terms of supporting the workforce. The government not only pays for training of healthcare workers, doctors, nurses, and all other cadres, but the government is also the main employer of healthcare workers. I think also we've heard from discussions in this platform and also in the previous roundtable that we're one of the countries which is committed to the Abuja declarations. I think, this demonstrates really good political will and commitment. But I think, even with all the gains that have made over the years, we are still concerned about what the future holds. We currently are facing some economic challenges with the diamond market not doing so well, which has been the main source of our GDP. So it's really interesting in terms of what we're thinking about going forward. We have a new administration that is working to re-engineer our health system. Currently, there's a big health reform with primary health care, revitalizing primary health care. And what this means is that some of the functions that were under Ministry of Health have been moved to local government, decentralizing those functions and making sure that, we improve in terms of efficiencies and effectiveness and getting those services closer to the communities, and also aligning them, I think, with the political structures so that there's ownership from the ground up. Because I think, with the central mechanism, with Ministry of Health being very central, I think sometimes we were not doing so well with engaging communities and making sure that communities have ownership of their own health and that they ask the right questions and, advocate for better health outcomes. And I think just another example that I think is doing really well in terms of supporting substructures without donor support is Rwanda. I think this is where we can also learn from because they have invested heavily in community healthcare workers. And Rwanda and Ethiopia have invested really well in community health systems, and this is an area that we haven't done so well. Most of our services have been really more at facility level. And, I think these are some of the things that we can learn on and leverage on going forward and see how to expand them across the continent. Over.
Great response. I'll move on to our next question, and that will be to Dr. Tobias. In your experience, what other contexts, and in other contexts that you're familiar with, what key factors have led to efficient, scalable, and sustainable solutions?
Thank you, Dr. Semo. In my own experience, one of the factors that contributed to successful scalable interventions is the community involvement. Community involvement has played a major key role in scaling up of programs, TB, HIV programs in our settings. The community involvement is very key. We've had in our setting, the primary healthcare setting, we have volunteers whom in the past we called them community health volunteers. Currently, they have been assigned the role of promoting preventive promotive health, and they're given some stipends. They're now called community health promoters. So this experience on community involvement, we saw it during the piloting of universal health coverage in 4 counties. In our country, we have 47 counties. Initially, the piloting was done in 4 counties with different demographic data. And in the current regime, the UHC scale-up borrowed a lot from the piloting of the UHC in the 4 counties. And it has been very key in informing the scale-up to the 47 counties. And community involvement is very key. We have even now formed what you are calling primary care networks in the counties. And so far, the scale-up to all the 47 counties is moving very well. So community involvement is very key, especially in scaling up programs that are geared to alleviating the problems of the communities. So the evidence, also the other factor is evidence. The data must be accurate. Otherwise, we won't know where we are coming from and where we are going. So the data, it has to be evidence-based, what you say, supported by data is very crucial. We must also align the government's involvement for the support and leadership. So the government provides incentives. And for the first case I gave you about universal health coverage, the national government are working closely with the county governments in incentivizing the role of the community health promoters. The national government gives a stipend of 5,000 Kenyan shillings, whereas at the county, they give the reciprocate amount of money, 5,000, to support them in their work of visiting from house to house in promoting referrals, health promotion messages, and also facilitating taking basic measurements like blood pressure, blood sugar, and body mass index. There is also the other factor of involving other partners. Involvement of partners is very important across for scalability, including the private sector. This one, so that it should not lead to duplication and again inefficiency, like I said. So it's not only enough to be technically correct in the health intervention, but we must have those factors interplaying together so that a scale-up is smooth and efficient. So that is in our context. Like I've said earlier, is the community is a very important. The evidence-based evident data backed up with the data, so that monitoring and evaluation of the same is effective. And
Thank
also,
you.
yes, then I think I'm going back to what I had said, but those are the most important factors among many other factors that you need to consider for an efficient, effective scale-up.
Thank you so much.
Thank you.
Thank you so much, Dr. TBS over there. I will move on to the next question now, and this is to you, Dr. Olaifa. Can you share examples of locally developed innovations that have led to measurable cost savings or improved health outcomes?
Yes. So I'm looking at maternal and child health in a way, but from two angles. So in a state in the south region of Nigeria called Zoey State, for example, and one of the things that the government did in 2009 was to offer free care to pregnant women and children under 5. This resonated with the people in the state, not only the state, but also in other states within that region, to the point that when women were in the other states and were pregnant, they would also just travel to the state so that they can access the free services, which kind of like created a big burden for the state, who had estimated based on their population that it would only cost this much. One of the things he was able to do was what they realized was that they had a delivery rate increased to about 90% in that state, and which also led to reduction in home birth. But their maternal mortality rate fell from 745 per thousand live births to 112 per thousand live births. That's an 84.9% reduction. Because of the concerns of the sustainability, what they now had to do was to bring in residence token enforcement. They brought in additional hospital training programs. They got partnerships with other funders. And because also those who don't deliver at facilities, they're either delivering at home or delivering at TBAs. So when you now have that upsurge in delivery rate at the facilities, obviously the livelihoods of the TBAs will be affected. So one of the things they did was to invest in alternative livelihoods for the TBAs. The program in itself has evolved into what we call the Abiyamo Maternal and Child Health Insurance Scheme. It still offers free care, but for those who can present residency evidence. But that's one successful one. The other was in the south region of Nigeria, which is Delta State, and there the state government actually worked with private investors to revitalize 15 primary healthcare centers. And what they now saw was that their outpatient visits rose from 8,000 in 2019 to about over 30,000 in 2021. And their maternal and under 5 deaths dropped to near zero. Specifically, what they recorded was that they had 0 maternal deaths in those PHCs, which are private public partnership PHCs, from the inception of the program to 2022. And the under 5 mortality was about 0.7 per 1,000 live births, which is a far cry from 53 per 1,000 live births that they used to record in the state. Currently, the government is actually working on what it refers to as the Maternal and Neonatal Mortality Reduction Innovation Initiative, which we coined as MAMI, where we are trying to reduce maternal and neonatal deaths by 30% across 172 high-burden local governments, learning from some of the things in which we've done, like the 2 examples in which I presented. And what we're trying to do is to actually strengthen primary health care through expanding the basic healthcare provision fund coverage, working with communities to mobilize women to access to services, using MAMI vanguards and work development councils, engaging with traditional birth attendants as well. We are bringing in emergency obstetrics and neonatal care to those communities, deploying essential commodities, And then, of course, ensuring that there's accountability for what we're doing. Funding is both government and development partners, with 40% to be financed by the government, 60% from development governments. But those two state interventions are some of the pride and joy of Nigeria, really. We do believe that the MAMI that we've set up now can go a long way to help improve Nigeria's indices in maternal and child care. Over.
Thank you so much for those great examples. It's really interesting to see how when you tweak certain interventions, they improve utilization, they improve, as you said, indices, and these are just great examples of how this has been done. I think what we want to see moving forward, Dr. Oleifa, is how we can transition from development partners funding this to the government of Nigeria and its collaboration with the private sector taking this on fully. All right, moving on. This is for you, Dr. Dakobe. Beyond government action, what standout partnerships among government, civil society, and the private sector have demonstrably produced more health for the money?
Yeah, so a partnership that stands out for me in my context is the partnership between the Botswana government and DBS. This is a partnership that has was established, before even independence, and I think we have seen the fruits of this partnership. It has resulted in access to quality health services in rural areas, particularly around mining towns, with the mining hospitals expanding services to the communities in the periphery. This partnership has also helped us as a country to be able to provide the free ARVs that I mentioned earlier, being able to provide that for all citizens. We've also seen this partnership strengthen the capacity of local healthcare workers to be able to provide services. I think we're at an interesting time because we're seeing a decline in the dependence on mining and on diamonds, and we now need to expand our reach even in the private sector beyond just these examples, these models that have worked before, and see how they can be applied to other industries and other sectors in the country. And I think these discussions have already started. We're embarking on introducing a national health insurance, which will require sourcing for domestic funding, especially in the private sector. So I hope that some of the lessons learned from the partnership with DBS and other long-standing private sector partners will be applied going forward. We also have really good examples. I think I mentioned some earlier in partnerships with communities and community organizations, community-led organizations that usually also are value for money, making sure that civil society is well resourced to reach beneficiaries in very cost-effective ways. And I think also there's a lot that can be applied from other African contexts. My country doesn't have really good, strong community systems. It's something that we're working on. So I think that I've heard really great examples from other panelists on this call, and I hope that those are some of the things that can be taken to scale. There's some other small initiatives, especially around innovative ways to provide services, like decentralized drug distribution, which are some of the things that we tried out with PEPFAR funding. And the question now is whether somebody else will pick up the tab and make sure that those initiatives are scaled, like introduction of digital lockers for drug distribution, using pharmacies, private pharmacies. There's a small project here with NCDs that uses private pharmacies, but it's really, really at a very small scale. So I hope that some of those initiatives from the HIV era can also be scaled. And you know, again, funding is a big challenge, but hopefully those can be scaled going forward.
Thank you so much for sharing those examples, but also for sharing some of the concerns that exist in Botswana right now with the diamond industry not doing well, and how there is need to pivot and look for other innovative partnerships. So this will be our last question to the panelists, and this one will go to Dr. Kibias. Are there evaluation frameworks that most accurately show whether health programs are delivering value for money and maximizing efficiency?
Thank you, Dr. Semo. I'll be brief. In our context, in our country, every 5 years we carry out demographic health surveys, and it gives a feeling about the outcomes and looks at the money spent versus the outcome. We have other frameworks that are in use in our region. We have the cost-effective analysis that can look at the cost versus the outcome. We also have databases run by WHO, for example, the Compendium for UHC looks at as a database for investment in UHC and the outcomes versus the outcomes. So other frameworks have also been used in our country, like the report include result-based financing. It looks at the results based on the finance given, and that brings out the element of accountability. So because it has to look at results. There is also the routine monitoring and evaluation, which in the past has always been looking at the programs, but this should be employed across board so that to inform real-time corrections or in-time corrections. And of late, in our setting, dashboards have been developed, real-time dashboards that gives decision makers an opportunity to make timely corrective measures where money is flowing and the results are not being realized. And this also cuts on inefficiencies. I think we have seen other international arrangements that monitor progress towards targets, like the joint expert evaluations by UN team of experts. I think those are the most commonly used frameworks in our region for monitoring fairly accurately how efficient funds that we allocate in the health sector. Thank you.
All right, thank you so much. I want to thank our panelists for such insightful contributions and a rich, thought-provoking discussion. So now we're going to open up the conversation and turn to questions from the audience. So let's see if there are any questions that have come in from the audience. So more health for the money also entails being deliberate about prudent procurement. More than 70% of health expenditure is on supplies, and yet in most countries, leakages are imminent, combined with weak supply chain systems, which create inefficiencies. Embedding value for money elements is also key. Do any of the panelists have a comment on this? Wame, maybe you could tackle that question. Happy to repeat it again. It's more like a comment. More health for money also entails being deliberate about prudent procurement. More than 70% of health expenditure is on supplies, and yet in most countries, leakages are imminent, combined with weak supply chain systems, which create inefficiencies. Embedding value for money elements is also key. Do you agree with this, or don't you?
I strongly agree with that comment. I think that we see a lot of inefficiencies in our procurement systems. One way that I think in my context that I've seen us trying to address that challenge is by introducing technology, digital ways of managing supply chain, because usually the inefficiencies are really because we rely so much on paper-based systems. Besides the other issues with, the actual procurement processes and corruption sometimes. But I think, introducing strong supply chain systems could be a way to improve efficiencies in procurement systems. Yeah.
Great. Thank you so much. Another question that came in, and Dr. Olaifa, I would like for you to respond to this one, because you talked about the multi-sectoral collaboration. In terms of efficiency in health, what is the panelist's view on impact and contribution of collaboration between public health and other sectors like agriculture, food and nutrition, and private sector, especially on logistics?
Again, it's about countries identifying opportunities. I think one of the things, a classic example also was when in the HIV space we were having challenges getting to some areas that were hard to reach. And one of the things that we were able to do was have the conversation with the military who have bases there if they can help us, which they were very happy to do. So countries have to identify what is playing out in their own context, identify who they can leverage to get things done at the end of the day. So there are different people that we can leverage on, either from the police or even the private sector, yes. The other things that we've also played around with was having the conversation with the Union of Road Transport Workers to help us move commodities to other areas, as the case may be. But I think one of the things we're currently doing in the country, it's actually in the pilot phase, is to actually work with our postal services to see how, for example, we can move samples from facilities to reference labs, as the case may be. So opportunities are there. And like I said before, we need to learn to reach out from our sectors to other sectors to see how we can leverage what they have to get things that we need to do done.
Thank you for that response. Dr. Kivias, can you share any examples of how digital innovations can be used to expand reach and quality of services and increase efficiency?
Thank you, Semo. I think we cannot overemphasize the role of technology in expanding access to care, especially in the space of UHC, universal health coverage. In our country, for example, the community promoters who are at the level of the household are already using computer gadgets for collecting data, very critical data that is real time. We can know how many households they have visited per day, how many people they have measured their blood pressure, how many clients have been referred, and how many have been provided any form of measurement or any intervention at that level. So the role is very huge. Even during the when you are passing messages of when outbreaks or of disease, mass SMS, short message text messages we use technology. We use the mobile phones. The mobile phones coverage in our countries, like for Kenya, is very high. So we really leverage on the use of technology, and that is huge, is immense. The media and the social platforms. So it is in use in a big way.
Thank you. All right, thank you for those questions and answers. We're now moving into one of my favorite parts of the roundtable, and this is the open mic and collective reflections segment. Over the next few minutes, we'd love to hear from you, the audience, but this time we're not looking for questions. We're inviting your insights. Consider sharing what inspired or challenged you today. What should we stop, start, or scale? How might today's discussion apply in your local context? If you'd like to contribute, please raise your hand and I'll call on you one by one and we'll open your mic. And you'll have 1 minute to share your reflection before we move on to the next person. So let's get started.
Hi, good afternoon.
Yes, go ahead.
Okay, thank you very much. I want to thank the panelists for their good insights. I just want to highlight on one point. I understood everything they said, but I think that one thing that will help us, especially in African context, is to make good use of our funds, to channel the funds to the appropriate quarters. If the funds are for HIV testing kits and they are being disbursed, let it be used according to the channel of the disbursements, because part of the problems we are facing is diversion of funds. If diversion of funds can actually be handled properly or completely eliminated, then all these expected measures, all these innovations that we have talked about, definitely they will all be accomplished. Thank you.
Thank you so much, Kingsley, for your thoughts and reflections. We'll move on to Olumuyiwa. 1 minute.
I'm Dr. Olumuyiwa Olusonya. I am the managing partner and CEO of Insignia Health, a healthcare consulting firm in Lagos. So my contribution is on the approach the Nigerian government has used to address maternal mortality and neonatal mortality. That's the MAMI project under the sector-wide approach. I believe that other African countries can learn from this. The idea is to reduce maternal mortality, infant mortality across African countries. And we need to also prioritize universal health coverage through establishment of mandatory social health insurance across African countries so that we can promote efficiency and reduce multiple funding going to so many disease intervention programs, whereas the people don't have access to basic health care, to health insurance. So I believe that these disease intervention programs can be delivered through support through the social health insurance schemes. When people have access to health care through social health insurance, most of these diseases will be addressed. The indices will go down because of access. This is not going to hospital a day or 2 days. They have access to hospital care 365 days a year with specialists, with basic drugs and amenities. So the funding going to disease intervention programs can be channeled to support social health insurance schemes across the continent. A good program from Nigeria. I think it needs to be understudied by other African countries, but it's a stopgap. It can't be a permanent thing. Just to address that program, the indices for a few years, where we'll scale up our social health insurance and access will be to all the services will be under social health insurance. So that's my take on that. Thank you.
Thank you so much, Dr. Olumuyiwa. All right, we're moving on to Ahmed. Please, can you introduce yourself and share your insights?
Hello, thank you. I am Ahmed Baba. I am in Nigeria, Abuja, in the office of the Special Advisor to the President on Health. Thank you, panelists. This is a very thought-provoking and insightful session. my contributions would be around looking at the very basics of health, especially within the context of the social determinants of health. Because health is a complex system. It hinges on how well the support systems are. Issues around education, issues around the empowerment of the community, providing basic things like electricity, potable water, because in as much as these things are not strengthened, health would continue to be a problem. So the discussion here could be, how can we leverage on all the other resources? Because if you strengthen, say, potable water supply, for example, you're completely going to be managing things around waterborne diseases. Things around wash will be taken care of. And so that where the health sector is leveraging on the strengths of those components of the social determinants of health, which primarily is the basis for the Alma Mater Declaration in 1978 on the need to strengthen the primary health care. Because once that is taken care of, I think that would help in optimizing whatever resources comes directly to the health sector. Thank you very much.
Thank you, Dr. Ahmed Baba. All right. So we're going to end the open mic session now, as we're nearing the end of our roundtable. And I have to say, the panel discussion and the audience engagement has truly exceeded my expectation. Today's conversation offered rich insights and some real practical examples of how we can drive greater efficiency and impact within our health systems. As we close, I'd like to share a few takeaways that emerged from our discussion. The need to prioritize interventions, how important it is to strengthen primary health care. This is something that all the three panelists kept stressing. Digital health being a resource for efficiency, using data to make the decisions when it comes to budgeting, when it comes to deciding which intervention is most cost effective or needed is critical, and also partnering with the private sector and the community. We also heard about the strategic purchasing of health services and the need for a long-term vision for the health sector that will promote particularly primary health care. Another important thing that came up was the leveraging of interventions and collaborating within and without, and within and out of the health sector in order to be able to use resources efficiently and reduce wastage and duplication. As far as targeted interventions for ensuring efficiency, evidence-based budgeting was something that was mentioned, tracking budget execution, having prudent public financing mechanisms and addressing bottlenecks, having the whole sector approach to budgeting, and funding strategies that deliver the highest return on investment. In terms of HRH, some of the things that came up were the importance of task shifting. We've seen task shifting working in HIV programs and malaria and tuberculosis programs. Now we need to adapt this to other disease programs. It's important that we make sure our pre-service institutions are actually training our healthcare workers in skills that are needed when they come out and they start they become part of the health workforce. Leveraging technology such as IRIS and using this to distribute healthcare workers more efficiently. Again, we also heard in terms of budget inefficiencies is to look at interventions that are cost effective and to use single funding mechanisms. Great examples from Nigeria on how sector-wide approaches were started for programs that were outside of HIV, TB, and malaria, but now how these have now been enveloped in and how health interventions are being aligned with national priorities under a unified approach, and how data is used to guide cost-effectiveness interventions. There were some practical examples that were provided on how we're not relying on external donor support, and obviously Botswana came through as a great example. Its strong commitment to the HIV response. Actually, the fact that Botswana's HIV response, national HIV response, started before PEPFAR, and the fact that the government has been procuring most of the drugs, the government has been funding the health workforce that's been providing HIV treatment is a great example. Other examples that came up of practical examples are from countries like Rwanda and Ethiopia who have invested in their community health systems. Involving the community through the community health volunteers and promoters is seen as something that's efficient, scalable, and a sustainable solution. It also, there were some great examples of locally developed innovations, the free MNCH program in Nigeria that led to 84 or 85% reduction in maternal mortality, and also some of the revitalization of primary healthcare facilities that are happening in collaboration with the private sector in southern Nigeria, particularly in the Delta State. We also spoke about partnerships. An example that was shared here was the partnership between Botswana and De Beers, the big mining company that has resulted in access to quality healthcare in the country, particularly in Jardin and Orapa, where the big mines are, and there are big healthcare facilities around there. But also with the downturn in the economy of Botswana and in the diamond market, how important it is right now to look at other collaborations with the private sector and see how those can continue to bring about scalable efficiency in country. The introduction of a national health insurance scheme in Botswana was mentioned as one way of collaborating with the private sector. And then as far as frameworks, evaluation frameworks are concerned, we also heard about DHS, the Demographic Health Survey, the cost effectiveness analyses that are being done in Kenya regularly, results-based financing, which looks at accountability, and also how we can expand our routine M&E to provide us with real-time data and dashboards for decision-making by the decision makers were some of the other things that we learned about today. So at this point, thank you all for joining us, and I want to extend my heartfelt appreciation to our distinguished panelists for their insights, candor, and thoughtful contributions. I also want to thank the audience for your engagement, reflections, and excellent questions. Your voices are critical in shaping the way forward. Let not the conversation end here. I encourage all of us to take what we've heard and translate it into action in our programs, our policies, and partnerships. We're at the end of our roundtable, and before we say goodbye, I'd like to remind all of you of our next session that will be held on July 30, and this one will focus on money for health, mobilizing sustainable financing, and we look forward to seeing you then. Thank you very much, and goodbye.